some history. Zygoma implants were first introduced in '98 by Dr. Brainmark, who was a Swedish physician and researcher. He's widely acknowledged as the father of dental implantology. Malavez and his colleagues described zygomatic implants as self-tapping screws in commercially pure titanium, as well as a well-defined machine surface available in lengths of typically 30 to 52.5 millimeters long. And there's a 45-degree angulated head to help compensate for the angulation between the zygoma and the maxilla. The original technique was a two-stage delayed loading until Miglioranka and his colleagues presented favorable results and conclusions regarding the immediate loading of zygomatic implants, which is the basis of this whole talk. So down here, you can see a zygomatic implant. This is a Brainmark zygomatic implant. The threads run along the entire body of the implant, and then you can see the 45-degree head. I'll talk a little bit later about some of the issues with the threads that run along the entire body. Most of the implants that we work with now have threads that only engage the zygoma, because if there are threads that engage soft tissue, that could help encourage dehiscence, which is not a good thing. And there's a picture of Dr. Brainmark in black and white. So just to refresh a little bit of anatomy, each zygomatic bone is quadrangular in shape and composed of 3 processes and 4 articulations. The processes are the temporal, temporal. So we have helps develop the zygomatic arch. The frontal ascends superiorly, and the maxillary articulates with the maxilla. The articulations, there are 4 of them. They're basically named after the processes. So we have the ZF, the ZM, the ZT, and there's one other one that's not a process. It's a zygomatical sphenoidal, which is located here. It helps make up the orbit. It articulates with the greater wing of the sphenoid bone. Some anatomic structures that I worry about when I'm doing these procedures. The first one is the infraorbital foramen, which if you draw a vertical line from the pupil, it ends up being very close to that line. It's about 5 millimeters below the orbital rim. And we need to be careful when we're dissecting not to traumatize this, this bundle. The orbital floor is also very important to consider. It dips down several millimeters, so it's not a flat bone, it's concave. So when we're doing this, we need to take that into consideration to avoid penetrating the orbit. In terms of our pre-surgical evaluation, the next few slides, we're going to pretend like we're working up a case. Patient presents, their chief complaint can be, I'm having trouble wearing dentures, would like to know more about some implant options. So the first thing that we all typically do is we take a good H&P. So we'll take the medical history, medications, surgical history, allergies, social history, drinking, smoking, recreational drugs, things of that sort. Some of the red flags that we might run into as we're doing this, that I pay particular attention to, and I'm sure everyone here does as well, is cancer treatment with head and neck radiation. Possible bisphosphonate use. Bisphosphonates are things like Fosamax, alendronate, Boniva, Actonel. These should all sort of warrant further conversation with the patient. Denosumab, which is Prolia and Xgeva, and tobacco use is also something that could be concerning. And these are not technically contraindications, but these are things that we sort of need to delve deeper into as we're working this patient up for implants. And then patient exam. So basically go through your normal exam. I pay particular attention to smile lines, gingival show on full smile, vertical dimension of occlusion when we're working up full arch cases. Next, we'll take some imaging. So who here has panoramic x-rays in their office? Perfect. Most of you. So after I take a pan, I go through it systematically. I usually start with the condyles. These condyles are pretty well seated, no flattening, no osteophytes, no subcortical thickening. And then I work medially. So the sinuses are very well pneumatized in this patient. As we proceed medially, septums, midline, turbinates look normal. Teeth are usually the last thing I look at. So after the maxilla and the joints, I take a look at the mandible. There's no signs of pathology. There's some atrophy in the posterior mandible. All the remaining mandibular teeth are root canaled, and there's a bridge in place. And we'll take some further imaging with a 3D evaluation. So this will help us determine what kind of bone volume we're looking at. So on the top left, it's an axial slice of a CBCT. We're at the level of the maxilla. Here's the airway. Here are the ramuses. And we can appreciate how thin that maxillary bone is. To the right of it, we can see a 3D reconstruction of this view. And below it, we have sagittal cuts to evaluate the width of the maxilla. So very minimal width, not a lot of height. And this is basically bone that's throughout the entire maxilla. So we don't have a lot of bone to work with for implants, unfortunately. In terms of treatment planning, there's something called the Bedrossian classification, and this is something that we can use when we're evaluating bone stock. If there's not a lot of bone in certain areas, it'll help. We'll basically be able to adjust our treatment plan for these patients. So the Bedrossian classification gives a guideline for the surgical approach to be adapted. This is done by reviewing the patient's imaging. The maxilla is divided into several zones. Okay. Zone 1 is between canine to canine. Zone 2 includes the bicuspids, and zone 3 includes the molars. All right. There is a zone 4. The zone 4 is the zygoma. So if we're treatment planning a case, and if there's sufficient bone in all 3 zones, we can do whatever our hearts desire with this patient. We can place axial positioned implants. We could do bridges. We could do hybrids. We could do whatever we want. So the options with these patients are limitless. Pretty hard to come by, especially finding good bone in zones 2 and 3 are not usually very easy. Next option, if there's sufficient bone in zones 1 and 2. So if we don't have good bone posteriorly by the molars, what are our options? So one option is something that we're all pretty familiar with. It's sort of the classic all-on-4, where the posterior implants are angulated to help avoid the sinus. And this is done to improve the anterior-posterior ratio so that we can get a good restoration for this patient. Moving forward, if we only have bone to work with in the anterior maxilla, what are our options? So usually with an all-on-4, we'll have good bone in zone 2, where we can position the implants to get, maybe by a second bicuspid development for that prosthesis. So what can we do? Well, one option is we can do 2 to 4 implants in zone 1. So anteriorly, if we have bone to work with, we can put implants there. Posteriorly, we can't angle implants, so we'll have to do zygomatic implants. So there would be 1 zygomatic implant for each side. The alternative to this would be bilateral sinus lifts and augmentation to develop bone in zones 2 and possibly 3. This usually takes some time, usually 6 months if everything goes well, before we can go back in and do implants. This is what something like that might look like. So we have 2 to 4 implants, in this case it's 3, in the anterior maxilla in zone 1, and deficient bone in zones 2 and 3. So we have zygomatic implants bilaterally, and we have our hybrid prosthesis. If there is no bone anywhere, kind of like the case that we just saw, our only option is quad zygomatic implants, which is 2 zygomatic implants into each zygoma. Even if we do bilateral sinus lifts, we're still not going to have bone in the anterior maxilla. So we're going to need to find a way to compensate for that. We do that by doing quad zygomas. So 2 implants on each side into the cheekbones, and again, nice hybrid prosthesis. So in terms of case selection, there are times when we just have to say no and come up with a different option for the patient. In these cases where an absolute contraindication is an acute sinus infection, obviously we don't want to put zygomatic implants into the sinus if there's an acute sinus issue. These patients typically get sent to ENT to help resolve that issue. If they're able to control it, then we can proceed. The other contraindication could be a pathology. So the pathology should be taken care of prior to any zygomatic implant placement, and this goes for any type of implant placement. And if there's uncontrolled or malignant systemic disorders, obviously that takes precedent over the implant case. Relative contraindications are chronic sinus infections, cigarette smoking, more than 20 cigarettes a day, zygomatic implant placement in patients that use bisphosphonates like Prolia and Xgeva, Fosamax, alendronate, as well as denosumab, is currently debated. The nice thing about Prolia and Xgeva is if we wait about 6 months, the risk of hemorrhage gets pretty close to 0, according to a lot of studies. So the longer you wait after Prolia, Xgeva tends to be a little bit nastier. I've seen a lot of cases of hemorrhage with Xgeva. Prolia tends to be a little bit nicer, but still the guideline is 6 months and the risk goes down to 0. If we're taking teeth out, and if there's an acute infection or patient's in a lot of pain, sometimes we go over the risk of hemorrhage with the patient and take the tooth out, because we have to balance the risk of infection. So in terms of workflow, it's very similar to that of the hybrid workup. So the first thing that we do is establish VDO, take preliminary impressions, bite registration. I'm sure I'm simplifying things a little bit, but lab will send back the provisional prosthesis or appropriate trays for impressions and for next day loading. Then we do the surgery, and then we can either do a chairside conversion or take impressions and load the case a day or 2 after. Wait about 4 months or 3 or 4 months, and then deliver the final prosthesis. So in terms of the surgical approach, I typically do these cases under general anesthesia. So patient will typically be intubated for this. Local anesthesia, just as I normally would. Crestal incision from tuberosity to tuberosity. We need really good exposure for these cases in order to access the zygomas. I usually do a midline incision, again, to help flap this open. So orient ourselves. Here's the zygoma. This is sort of the anterior wall of the maxilla. So what I typically do is I use a round burr to make a channel into this through the anterior wall of the maxillary sinus. And this does a couple of things for me. Number one is I can see the membrane. This is a Schneiderian membrane. I elevate that out of the way so that I can visualize sort of anatomy. So I can see the orbital floor. I can see where it dips down so that I can avoid it. And it also helps create sort of a channel where my implant will be. So this is sort of at a 45-degree angle. The implant that we have already has that 45-degree head built into it. So we're aiming for 45 degrees into the zygoma. Once that's done, before I use a twist drill, I'll use a round burr to initiate that osteotomy so that the twist drill doesn't slip around on the zygoma. There are 2 twist drills that you use. After the second twist drill, we can torque our zygomatic implant in. So this zygomatic implant, they're all hand torqued in. They torque to 45 Newton centimeters. And this is showing both zygoma. So this is a quad zygoma case. Both zygomatic implants are in place. And for all of the cases, I pull buccal fat over to prevent dehiscence. Even if the zygomatic implants are within the sinus itself, I always pull buccal fat over, helps prevent dehiscence through soft tissue. This takes 5 minutes to do, and it helps prevent issues for the patient.
Did you do that after you would have problems?
No.
Did you ever have dehiscence and then you were like, yeah, I should do that?
Nope.
No?
Nope, from the get-go. Oh, it's just a good preventative way to make sure that it doesn't dehisce. So I haven't had any dehiscence cases, so maybe it works. So here's a panoramic X-ray showing the quad zygoma positioning, and again, the prosthesis loaded onto the implants. So there's something called the Zyga classification, which is, Zyga stands for Zygoma Anatomy Guided Approach. And basically what this attempts to do is it attempts to relate the position of the zygoma to the maxilla, and it'll help guide our placement of these implants. So what it wants to look at is really the buccal concavity of the maxilla will determine what type of Zyga classification it is. So if we look at type 0, there's no buccal concavity. It's pretty straight. We can actually keep some buccal bone in place by putting the implant through the palate and engage the zygoma, as you can see here. So buccal crest is intact. It doesn't have to be, but it seems like it could be nice. Implant engages into the zygoma, and it's basically through the sinus. As we proceed down, we take a look at type 4. It's pretty concave. So what happens is you can't position the implant through the palate as much, because if you do, you're going to end up with a very palatal prosthesis, and that creates bulkiness. Patients can have a hard time with speech, and it's just uncomfortable. So they basically have to be, channeled along the buccal aspect of the zygoma, or sorry, of the maxilla. So what happens is a lot of the implant becomes extra sinus. So there's a lot of soft tissue contact with the implant, and this can lead to issues like dehiscence. So all of these implants, the purpose of these implants is to be, prosthetically driven. So in order to do that, we have to sort of compensate by leaving them out of the sinus and doing as good of a job as we can with our position of the implants. So after the implants are in, one restorative approach is to load the case same day. You could use the existing removable prosthesis, or you can have the lab make a prosthesis. I'm hoping this video works. This is from BioHorizons, courtesy of BioHorizons.
Confirm that the abutment platforms are free of any debris or soft tissue. Place the multi-unit healing caps and hand tighten using the hex drive. Syringe bite registration material into the denture that will be used for the conversion. Place the denture over the multi-unit healing caps and have the patient close into light centric occlusion. Once the bite registration material has set, remove the denture. Use an acrylic burr to create small holes through the denture at each point where an indention was created by the multi-unit healing caps. Place the titanium copings onto the multi-units using the prosthetic screws and a long 050 hex driver. Hand tighten. Try in the modified denture to verify the alignment of the holes in the denture and the position of the titanium copings. If they are in alignment, widen the holes and ensure that the titanium copings pass freely through them. A minimum clearance of 1 millimeter is recommended on all sides of the titanium coping. Modify the height of the titanium copings to ensure that the patient can bite into occlusion. Place a rubber dam over the titanium coping to protect sutures and to block out undercuts. Place cotton into the titanium coping screw channel and cover them with dental wax to prevent acrylic from entering the channel. Place the denture over the titanium copings and syringe flowable acrylic into the holes and around the titanium copings. Allow the patient to bite into light centric occlusion. Once the acrylic has hardened, remove the dental wax and cotton from the titanium coping screw channels and remove the prosthetic screws. Remove the modified denture and the titanium copings will be picked up within the denture. Add acrylic to any voids around the coping and shorten the posterior cantilever. Remove the denture flange to avoid any contact with the tissue and smooth any rough or sharp surfaces to complete the provisional restoration. Place the provisional restoration and torque the prosthetic screws to 15 Newton centimeters. Place a resilient temporary material into the screw access channels and fill the remainder of the channels with a composite resin.
So I know that was for a lower arch. It's virtually the same exact thing for
Is there ever an instance where you can't load it
Confirm that
forward?
the abutment flap.
So if, sorry, the question was,
Is there any instance where like you can't load it, like maybe you don't get the primary stability of the implants?
yes. So if, the threshold is 120 Newton centimeters of combined torque. So when we put our zygomatic implants in, they count for 45 each. So if you do bilateral, single zygomatic implants are at 90. So we usually need at least, one or two in the anterior maxilla. If you're doing single zygomatic implants, you need at least two, and that usually gives you the 120. If you don't torque somewhere, then you can't load it.
Then what do you do? Wait.
Then you wait. Yep, just like with like a normal like arch. So you'd have to leave it buried, keep them in a denture, removable, and then load after they integrate.
Have you ever had that?
No.
So you-
Nope, not yet. So the other restorative approach can be same-day impressions. So impressions with a custom tray and a bite transfer jig sent to the lab. Lab will send back the temporary prosthesis, and we load it the next day or 2 days later following that in the same fashion that we just saw. And this is how it looks. So in terms of postoperative considerations, sinus precautions are paramount. It doesn't matter sort of what Zyga classification we're working with. There's some component of these implants into the maxillary sinus. So sinus precautions are important. No nose blowing, no spitting, no smoking, avoid straws, no heavy lifting like Dr. Capuano, and encourage open mouth sneezing. Diet restrictions are also very important. You don't want patients biting into bagels and pizza and things like that and rocking these implants and traumatizing things. Pain and antibiotic regimen, just what you would normally do for an arch case. Chlorhexidine and oral hygiene are also very important. Outside of the realm of a typical all-on-4, post-operatively, we can expect some mild to moderate periorbital edema and ecchymosis due to the retraction and exposure to get these zygomatic implants in place. In terms of complications, sinusitis is the most common complication with the zygomatic implants. The incidence is 0 to 26.6. Most cases are clinically asymptomatic. They usually only pop up on radiographs. When we see that, we can do things like decongestants, like Sudafed, which patients can get over the counter, or you can prescribe them if you'd like. Flonase, which is fluticasone, can also be helpful. For cases with discolored nasal secretions, symptomatic sinusitis essentially, foul odor, foul taste, facial tenderness, congestion lasting more than 10 days, we treat that with antibiotics. So that gets augmented. All right. For recurrent cases, let's say patient comes back with symptomatic sinusitis after you treat them with antibiotics, and it's time to go to ENT for a possible functional endoscopic sinus surgery to clean things up, maybe perform an antrostomy, whatever we need to do to help relieve this scenario. This is pretty uncommon, not something that I've seen.